Good evening, everyone. On behalf of Intas Pharmaceutical Limited and Janet Division, I, Dr. Mithilesh Nayak, welcome you all to this sixth episode of Endocrine Talk Show. So, this Endocrine Talk Show is specially designed to address various clinical challenges which Indian clinicians face in their day-to-day clinical practice while treating endocrine disorder. And today we are live again with yet another interesting topic, that is the hormone replacement in various conditions, maybe insulin replacement in type 1 diabetes, the thyroid hormone replacement in hypothyroidism, and post-menopausal hormone replacement therapy. So what are the challenges and how better we can manage? How can we address the challenges? We are having with us a panel of experts who are going to help us in addressing the challenges. And moderate today's session, we are having with us our course director for the program, Dr. Subhankar Chaudhary sir. He's a professor and head at Department of Endocrinology at SSKM Hospital, Kolkata. He is a former editor-in-chief for the Indian Journal of Endocrinology and Metabolism and past president for the Endocrine Society of India. He is also a member for Subject Expert Committee CDSC of Government of India and having more than 210 publications in various national and international journals. So with this word, I hand over the digital podium to Dr. Chaudhary sir and request him to introduce our panelists for today's program. Over to you, sir.
A very good evening and a warm welcome to all our participants this evening. This program, as has already been mentioned by Dr. Mithilesh, is essentially a program for the physicians, maybe by the endocrinologists, mostly by the endocrinologists. And we are fortunate that each time we are blessed with fresh set of eminent people from across the country who kindly agree to share their experience and knowledge with all of us. This evening is no exception. So we have none other than Dr. P.N. Prasanna Kumar, who is a consultant endocrinologist at the Center for Diabetes and Endocrine Care in Bangalore. And we have another representation from Bangalore this evening. So actually, I think Dr. Prasanna Kumar was amongst the earlier ones to set up or develop the Department of Endocrinology at MS Ramaya Medical College, where he was a senior professor and head. He's been a past president of RSSTI, past president of Endocrine Society of India, and a past president of Indian Thyroid Society, and he's got numerous publications. We also have with us this evening Dr. Parag Shah, who is a consultant endocrinologist from Ahmedabad. So he is a consultant endocrinologist at Gujarat Endocrine Center. He also has got numerous publications and has been always he's been there with different conferences inside and outside this country. So welcome, Dr. Parag Shah. Thanks for joining. We also have with us Dr. Rana Bhattacharjee, who is the faculty in our Department of Endocrinology at IPGMER and SSKM Hospital, Kolkata. He is a wonderful speaker, a person who has got a very balanced head and with the deep knowledge, not only of endocrinology, but of medicine overall. He's got numerous publications already. So welcome, Dr. Rana. And we have a very popular Dr. Chitra Selvan, again from Bangalore, and she's currently Associate Professor of Endocrinology at the MS Ramaya Medical College. She is also an excellent speaker, a wonderful academic career to her name, and has got more than 40 publications. Welcome once again, Chitra. So when we talk of hormone replacement therapy, it refers to post-menopausal hormone replacement treatment. But for this evening, we have taken the liberty of broadening it and talking about hormone replacement in some of the commoner endocrine conditions. And as Mithilesh has already mentioned, we will try and cover type 1 diabetes, hypothyroidism, and menopause. The evening essentially should belong to all the participants, so you are free to shoot your questions. Please put down the questions in the chat box, and Dr. Mithilesh would eventually channel them to me. And I can maybe start off asking some questions on your behalf, but essentially, please feel free to put your questions. At the end of the day, at the end of an hour or so, if you find your question has not been answered, the reason could be one of three. A, we have run out of time. B, your question probably has already been answered, maybe in slightly different way by one of the faculties already. Or C, maybe it was not relevant to this evening's topic. So here we start. I haven't seen any questions yet, so maybe I start with something. And it's always a pleasure to have the experience and wisdom and knowledge of Dr. Prasanna Kumar. We always claim that type 1 diabetes, as distinct from type 2 diabetes, is a pure endocrine condition. It's just a matter of insulin deficiency. So it should be a relatively easy way to treat type 1 diabetes. Just give them insulin and it should solve the problem. Unfortunately, this does not quite happen in our clinical practice. So what are the challenges that you see, Dr. Prasanna Kumar? And I'm aware that you have one of the largest type 1 diabetes follow-up clinics under you. So you are probably the best person to tell us about it. Prasanna.
Good evening, everybody. Thank you, Dr. Subhankar. I hope my voice is clear.
Yes, sir.
Because your voice was breaking and video was running too fast or too slow and it was running. I hope it may be probably internet problem. Now I think this voice is clear because I see the internet speed quite high, 120 Mbps, as you can see, because yesterday I got 5G here. So our question is that what are the challenges in type 1 diabetes giving insulin? Because type 1 diabetes is next only to thyroid in children, second biggest hormone disease. In a beautiful article a few months back, even after 100 years of insulin discovery, that many children are not getting. We are not talking of Europe or Scandinavian country. If you look at children in Africa, still they don't need. Is it that they don't get it, they can't afford it, whether availability, affordability, or even adaptability? It's a problem also. All of them we see, whether richest of the rich, poorest of the poor also. Again, just because human insulin is available and available in plenty, unlike what we see is that about the analogs also from animal insulin and which went out because the supply could not be there, then we had human insulin. Now it is available in plenty, but still we see this problem that it is not available. What is the problem? Can you hear me?
Yeah, we can hear you. There's just a background noise. Yeah.
Okay. Yeah. Okay. So that is the problem what we see. And problem is not just availability. Let us say it is available, but many people may not get the insulin because of affordability and all that, where it is not a right of a child to get insulin. We have been fighting Endocrine Society, RSDA, that it is a right of every diabetic child to get insulin. It is not. If it is available at the public domain for everybody, it would not be. All of us, I am sure all of us here are trying hard for the 3-4 decades. See, every child comes to us, get the insulin, whether they can afford it or not. So that is one problem, availability. All right, we provide, and there's no guarantee they will take 3 times, 4 times. Still, a lot of children are taking 1 dose, 2 doses, when they are supposed to take 4 doses. So these are the problems what I feel, that unless we change the mindset of the parents, caregiver, just providing insulin does not mean they are taking or they are taking sufficient. It's not like thyroid, you swallow 1 tablet. You have to take insulin day in and day out, lifelong. And they have to take not just once or twice or thrice, basal bolus. Because type 1 diabetes is a pure insulin deficiency disease. And this is one place only basal bolus insulin should be given. This is for the benefit of physician, pediatrician who are there. Please remember, none of the pre-mixed insulin, basal alone is going to work. Every child should be on basal bolus, 1 basal and 3 bolus insulin are necessary, whatever the difficulty, whether child is going to school or working, young or old, whatever it is. So we have to impress. So as Dr. Shubhankar said, 100 years, human insulin available, but still many people cannot afford human insulin. Not to talk about analogs, the short-acting analogs, long-acting analogs are the best for type 1 diabetes. Not even 10-15% of them can afford it or getting it. Just yesterday, one of my friend Graham Ogle from Sydney has produced a paper. He's part of Life for a Child Diabetes. He said that they have got 20. He wants to increase it to 150,000 children. And he says, where I look, India has the largest number of poor children with type 1 diabetes. He has dumped 30,000 cartridges with me. Another 70,000 cartridges will be dumped. If I can take it and deliver, I'm trying to get it like that. And their estimate, this is a mathematical model. We don't have an exact figure in India. Along with Harvard, we are working to get a mathematical model. Graham Ogle's model is there are roughly 6 to 8 million diabetics, type 1 diabetes in the world. It is likely to be 13 to 14 million children with type 1 diabetes. This is a prediction 2040. It was just published yesterday. We can go through that. So if there is a huge number, are we able to cater and deliver insulin? And how do we make these challenges is a big thing. All of us are working through those. If government can take over this, I think then like Western countries, every child should get it.
Right. So you sort of hit it on the nail, hit the nail on its head, as they say, in that insulin is not available, but even if insulin is available, it's a different matter, different ball game, whether they'll take it 4 times as needed. On top of that, we need to do the monitoring several times a day, the glucose monitoring, and then of course the other checks. So if we try and reduce the number of pricks, will that solve the problem? So Dr. Rana Bhattacharya, so if we have insulin pump, of course, I am keenly aware that most of our patients cannot yet afford, but if pumps in whichever country, most people with type 1 diabetes, if they can afford a pump, will that solve this problem? They don't need to prick 4 times a day, every day.
So pumps are actually a wonderful innovation, and they're becoming more and more sophisticated with time, and they are becoming kind of more closed loop, that is to mimic the pancreas with time. But there are some problems as well. Of course, the cost is a big issue, not only the cost of the pump, but also need for monitoring. There should be more intensive monitoring, possibly more than SMBG. So number of pricks, although the insulin pricks may be less, but the finger pricks, which may be actually bit painful.
But you do a CGM along with the pump?
So CGM, yes, but problem is that CGM continuously over the days on end, it's very difficult, and again it's difficult to afford. But continuous CGM with the loop and the closed loop system, it's very expensive. So that's a problem, sir. But again, many of the CGM needs calibration. Although the number of calibration, the requirement is becoming less and less, but still they need finger stick calibration. Number 2, so motivation. I mean, with pump, even with the most advanced pump with advanced algorithms, still you need to administer the bolus insulin. So basal rate may be adjusted by artificial intelligence even in the advanced pump, but still need for bolus pumping and all, and carb counting, all those things, and again doing the maybe CGMS, those require a very high degree of motivation. Number 3, the patients needs to be quite well educated and to some extent tech savvy. Otherwise, it's very difficult to understand the nuances. So these are the problems which we actually face with the pump, although it's a wonderful discovery. So, but it's very difficult to implement.
Yeah. And we think the more the alarms that come with the pump, the safer it is, the better it is. But I've had so many patients coming back to me and saying those alarms are damn bothersome, so I have turned them off. And
Yes.
their doctors also say it disturbs me no end in the night, so I have turned off those alarms. So the precise advantage of the pump is not being taken help of.
Yes.
Right. So we have got a question from Dr. Verma. So Rana, please be there.
Yes,
What are your thoughts on artificial pancreas? Do you see any role of artificial pancreas in managing type 1 diabetes in near future?
This is a question for me, sir.
From Dr. Verma.
Oh, okay.
Your
From
thoughts
Dr.
on
Pharma. Yeah.
artificial.
Yes, definitely. As I was saying, that artificial pancreas means the closed loop system. So basically, with the development of more and more sophisticated algorithm nowadays, which can be accommodated within a smartphone, even you do not need a separate device. So definitely, the artificial pancreas is the future, and we have a option of dual hormone delivery, that is insulin plus glucagon at a variable rate, mimicking the pancreatic secretion more and more. Of course, in future, we can predict that artificial pancreas will be there and it will be a game changer. But as of now, it's still under development. Maybe we have to wait another 5-10 years to see a full impact of that. But again, in the near future, I don't foresee a reduction of cost to a great extent of this artificial pancreas. They will still be prohibitively expensive, possibly.
Right. Yeah. Good. So, I know Chitra is very tech savvy, but Chitra, for now, let's sit back and think of an average type 1 diabetes attending your clinic, following up with you. So, how would you monitor that child?
Right, sir. So I think the management of a child or an adolescent with type 1 is the perfect place where you have to equally use your faculty of your brain and also your heart to get it right, I think most times. And it does lead to heartbreak, not just to your patient or patient family, but also the caring doctor. So all the issues which were raised by Dr. Prasanna Kumar and Dr. Rana are also the unique aspects of the care that we need to fold into the consult. So like any person with diabetes, we are going to be screening for comorbidities like blood pressure and lipid. Yes, even in children and adolescents with type 1 diabetes. We'll also be screening for microvascular and macrovascular complications. The only difference in a child with type 1 diabetes might be that you might not need to do this at diagnosis, but probably wait for about 5 years to begin your screening, or at about the time they hit puberty. Because puberty per se, the hormonal changes which happen around that time could lead to a spurt in all of these complications. Because type 1 diabetes is an autoimmune condition, it does make sense for us to screen for other coexisting autoimmune conditions at diagnosis and annually thereafter, specifically autoimmune thyroid condition like hypothyroidism. It would also make sense to screen for celiac sprue at diagnosis and maybe as dictated by clinical picture. Children grow, so it's important to track growth because that's a great indication of overall how well we are managing diabetes, also nutrition. So growth and puberty is something that we need to monitor at every clinical visit. Apart from that, I think spending some time looking at the injection technique, how they store their pen, whether they're really taking insulin 4 times a day, whether and how their self-care abilities are, and how their support from their family and peers and friends are. Those are all important factors because it's an extremely labor-intensive condition to treat, and it can get vary on the child, forget a child, even an adult. Adjusting to the diagnosis is a huge thing, and it's an invisible disability, right? So nobody can know that you're going through all of this, but on your mind, you're continuously thinking about your next dose of insulin, and even a simple thing like going out to play could be a big deal to a child, because they have to think about, will I go into low sugar, will I go into high sugar, and all of that. So they need a lot of screening for how they're doing. Would you like some support? And also mood disorders are reported to be more common in this group of people. Eating disorders are common. In Bangalore, it is not at all uncommon to have young girls with type 1 diabetes skipping doses of insulin to lose weight and to fit into clothes and to appear presentable. That's a very common thing that we're struggling with. And eating disorders overall don't really have like a very easy way of sorting it out. It's all very twisted and difficult to treat, especially if it happens in a child with type 1 diabetes. I think those are all the overall challenges. And also, I think as healthcare professionals caring for a child, we also have to be advocates for their care. Many times you have to address social issues, which might be completely beyond the scope of what we've been trained to do. But I think that's the gist of what caring for a child.
Right. And of course, we need to have some sort of idea or plan for glucose monitoring. Most of the time it's self-monitoring of glucose at home.
Yes.
Yeah, as of now, right.
Yes. So continuous glucose monitoring is very much available, and maybe it might be okay to say that it might be within the reach of many people, at least intermittently. So maybe you can try and use it for about a fortnight every 3 months or so to get a glimpse of what's going on with your sugar pattern, because as we've understood that it does evolve with time, and trying to adjust to the evolving glycemic excursions is one way of getting your HbA1c on the target. So that's also something which we can address. And also the ability of your child to adapt to technology changes. A 11-year-old child might be ready to optimally use CGM if they are attuned to it. So that's also something that you'll have to keep be attuned to pick it up and say, okay, maybe we can try CGM and maybe get the benefits out of it.
Right, great. So we started with the statement, and Dr. Prasanna also seconded it, that type 1 diabetes is a pure insulin deficiency. So the only treatment is insulin. But I'll ask Dr. Parag Shah as to his thoughts or his practice of using non-insulin as anti-hyperglycemic agents in type 1 diabetes. And I'll mention, at least make it easier, talk of 3 specific class of drugs. One is, of course, metformin. It's a drug itself, not class. The SGLT2 inhibitors and AGIs, alpha glucosidase inhibitors. Do you ever use any of them in type 1?
Yes, I think we all know that insulin, the basal bolus, is the ideal therapy, and people with type 1 diabetes will always need insulin. Unfortunate reality is most of the patients are not going to afford or accept the basal bolus therapy. So quite a good number of patients in India are on a twice-a-day premix insulin. In spite of repeated counseling, they take it for some time, they go to somebody else, somebody puts them back to twice-a-day premix insulin. So we need to have something which acts independent of the beta cell functions, which is deficient in type 1 diabetics. Like AGIs, which we all know that we are a carbohydrate eating country, pan-India. So whatever surge the carbohydrate would lead can be blunted down by giving the AGIs. And acarbose is approved in our country in type 1 diabetes along with the insulin therapy. So I do use acarbose when the patient is on a premix insulin twice a day and not ready to be on a basal bolus therapy, to blunt down the peak, specifically post-lunch peak, which is not covered by the conventional premix insulin given twice a day, and to bring down the dose of insulins and the peaks and leading to the less hypoglycemia. So AGI is, I think, one of the agents which can be used. Second is about the SGLT2 inhibitor. There are some data that yes, SGLT2 inhibitors can be of beneficial, being an insulin independent mode of action leading to glycosuria. But you have to be very careful because it increases the chance of ketosis. So any diabetic kid who develops acute infection or suddenly stops the insulin, the chances of ketosis would significantly increase. So if at all we want to use, we can use only in a motivated patients who are already on a insulin therapy, and because of the hypoglycemia, in spite of basal bolus therapy, analogs sometimes leads to hypoglycemia when you increase the dose of insulin. So bring down this 7-point 8 or 8 HbA1c to bring down to around 7. In a well-motivated, well-educated people, you may think of giving a small dose of SGLT2 inhibitor, provided they are not on a catabolic state, they are not going to decrease the dose of insulin suddenly or stop the insulins when they are feeling like nausea and vomiting. That is very common reason of people getting diabetic ketoacidosis, because for whatever reasons they are not able to eat the food regularly, they will skip the insulins, and then they will, if they are already on SGLT2 inhibitor, the chances of ketosis would significantly increases. Metformin, there are some data in a post-pubertal obese type 1 kids to reduce the insulin resistance. And the data are not very supportive of use of metformin or glitazones for post-pubertal. And the dose requirement or HbA1c drop or chances of hypoglycemia also does not significantly reduce. So I think AGIs, yes, we can use in a premix twice a day patients. SGLT2, if at all, only in a motivated patients who already are on insulin for at least 2 to 3 years, and you are very confident that he has understood the why we are giving the SGLT2 inhibitor, not to decrease the number of pricks or the decrease the 3 days to the twice a day or 4 times a day to 3 times a day, but just to have some added advantage of trying to bring down the HbA1c to the target.
Right. So I must admit, I have never used an SGLT2 inhibitor for type 1 diabetes. A quick question to all the three other panelists. Prasanna Kumar, do you use it, SGLT2 inhibitor?
I think if you use SGLT2 inhibitors, you may be sued because it is not approved by any of them. Second thing is they are more likely to get ketosis. Even type 2 diabetes, not well controlled, when they are put on SGLT2, they can see. Right now, that it is not advisable to use SGLT2 except you are doing for research. Only thing that I feel, I also don't believe in acarbose, oglibose helping postprandial. GLP-1 analog in obese type 1 diabetes is the only drug, there are two coming up, is the only drug that I use, not metformin, not acarbose or any of these alpha glucosidase inhibitors or anything. Only GLP-1 analog. It is a fantastic in obese type 1.
So, Prasanna Kumar, so GLP-1 is approved for use in type 1 diabetes?
I don't know. There are many studies,
Yeah,
but
I'm not aware.
Sure, there are many studies where it has shown. So many studies are available, and I have used in few of the obese type 1. The reduction of the insulin unit is more than 30% of weight comes down.
Right. So maybe Rana and
unlike
SGLT2 inhibitor.
No, sir, I haven't used in any of my patients.
And what about GLP-1?
No, sir, never. I only used metformin and AGIs.
Metformin, okay. And Chitra?
Yes, sir. And
So
AGI.
metformin and AGI I have learned from you, so but not
right. So we have a question actually in the chat box which is related to type 2. So it's not maybe quite relevant to this discussion. Dr. Khan, so what he says is, as per recent guidelines, GLP-1 receptor analog is first-line injectable therapy in type 2. There are many issues, including tolerability and cost. So do you think GLP-1 receptor analogs are suitable replacement of insulin in Indian type 2 diabetes? I think we can discuss it later if we have time. So we had a quick look at type 1 diabetes. We do understand that physicians by and large may not continue to have type 1 diabetics under their care, would possibly be referring to a center where there's an endocrinologist who has experience. So we wind up here for type 1, but we are open to have any other questions related to this. So we now turn towards hypothyroidism, which is commonly treated, diagnosed primarily by physicians and also treated by many physicians. So straight away, Dr. Rana Bhattacharya, what is the starting dose of thyroxine in primary hypothyroidism? Is it predictable, or is it dependent on just your experience? How do you do it?
Yes, practically, frankly speaking, it's on kind of instinct, the dose that we start. But there are some basic guidelines, of course. First thing that whatever dose you
So,
start, we can.
so the physician still needs to refer to you.
Yes, sir, definitely, sir.
They can't do
No,
it
no,
on
no,
their own.
no, sir. They can do it their own very well, sir. There are some
Okay.
guidelines. What I did, what I do, that I told. But of course, the physicians must start it in appropriate way. So the standard dose, the full replacement dose is around 1.6 microgram per kg body weight. That's the standard. But there are some exceptions, like if you have a milder hypothyroidism, like
Sorry,
subclinical
Rana.
hypothyroidism.
Sorry, Rana. So when we say per kg body weight, is it per kg current body weight or per kg ideal body weight? How do we do that?
So textbook says it's ideal body weight, but again, a patient who is very obese and a patient who is very lean both have similar ideal body weight. I would give I think we have seen that slightly more dose is required in obese individual. So it's somewhere between possibly the ideal body weight and
Fine,
actual body
fine.
weight, somewhere in
Sure.
between.
Thanks.
That's the yes, sir. That's the full replacement dose. But again, the patients with milder form of hypothyroidism, like subclinical hypothyroidism, often needs a very small dose. Like in adults, we can start with 25 or up to 50 micrograms, usually 25. Again, there are some situations where we can start straight away with the full dose, like in neonates, like in pregnancy, where the dose is even a bit higher. And in an average adult patient. But there are some situations where the starting dose is actually very low, like in elderly patient, particularly with a risk of the underlying cardiovascular risk or established cardiovascular disease. There we have to start very low and go slow. Again, in a very elderly individual, again, the similar kind of approach we usually follow. And in children, not in neonates, but beyond the neonatal age, we often start with a bit lower dose, not full replacement dose, because full replacement dose can lead to increase in ICT, intracerebral pressure, if it's used in a primary hypothyroidism or severe primary hypothyroidism with a full dose. So overall, depending on the degree of hypothyroidism, depending on the age, depending on the comorbidity, and some additional factors like presence of pregnancy or not. So based on these factors, you decide upon a particular dose of levothyroxine, starting dose.
Right. And as you follow up, let's say you're following up a person from age 45, 50, and maybe continues to follow up with you and comes at age 75. So what do you do? Do you change the dose at that time?
Sir, actually, my target TSH changes with age. Of course, I tend to keep TSH level bit higher in an elderly population because the keeping TSH in the low normal range may increase the risk of developing into hyperthyrotoxicosis rather because of less excretion of or less destruction of T4 within the body, and the elderly people are more susceptible to the adverse effect of thyrotoxicosis. Rather, a mild hypothyroidism is something that they can tolerate better. So the risk benefit, considering the risk benefit, I would want to keep the TSH in the upper normal. So I usually reduce the dose if the patient is otherwise stable.
So the patients, don't they ask you, so therefore my thyroid is getting better if you're reducing the dose?
Yes, so we need to explain that possibly. Yes, possibly it's not so. Because of the physiologic changes, you need a bit lower dose than usual.
Fine. So we have a question. Yes, Chitra. Yeah.
Dr. Rana, at what age would you relax the upper limit, and what would be the upper limit?
It's a continuum, basically. As I've said, just above 70, then maybe upper range of the normal range. But if it is, say, more than 85, 90, then I would keep it somewhere between 5 and 10, even I'm happy with that. So it's a continuum, and we have to take a call.
So we have a question from Dr. Dhiraj. And I think we need the experience of Dr. Prasanna Kumar to respond to it quickly, though. I've seen many clinicians are prescribing Ayurvedic supplement as an alternative to thyroid replacement and insulin replacement, frequently advertised too. Any thoughts on regulating such formulation by government, as many patients are taking both therapy together, Ayurvedic and the one which we prescribed? So overall, this problem, Prasanna.
First thing is, at least in hypothyroidism, it's not a life-threatening disease. And knowing fully well, adults take Ayurveda, homeopathy, whatever alternate this one. And many times we know that even in a well-established hypothyroid, and remission is possible. Somebody who's taking 100, 120, stops for 3 months, 6 months, comes back like that. So whether it works or not, don't bother about it. Right from the beginning, I tell patient, insulin is the only treatment. Never try any alternative treatment, because we have seen in the last 40 years, many of them being lured by this Ayurveda and other alternative medicines, stopping insulin. They go into ketosis. Many of them have died. So that's why my plea is, whether type 2 diabetes or whether hypertension, I don't care. It is patient choice. Last 40 years, we have seen, even everybody says it's a patient. Why we have alternate system? That means you can't ban it. One of the recent High Court ruling said a homeopath can give allopathic medicine, but not just only homeopathic. He should also give allopathic plus homeopathic. So that's why even court is not going to depend that it's a patient choice, but we have to educate them. Now, whether it is hypertension, this, let him do whatever it is. Day one, I tell them, never stop insulin. Your child's life is in risk. Please don't try alternate medicine, at least type 1 diabetes. And you know, for all other diseases in our countries, they'll use. Just a correction for that, what you asked that question, till today, FDA has not approved GLP-1 unlock for type 1 diabetes. So it is not approved. As a research, you can do few patients and all. There are a lot of studies, but again, it may be a problem. FDA has not approved, so GLP-1 is not. This is my take on what not only Ayurveda, alternate system of medicine.
Yeah. Thank you. So, Chitra, I don't know whether you see this sort of patient or not, but only the other day I saw a lady who was 60 kilos body weight, has been on a fairly stable dose of thyroxine, 100 microgram. Last time she attended, the TSH was normal, let's say 2 or thereabouts. But this time the TSH is 0.2. So what are the possibilities and what do? Do you reduce the dose? She is, let's say, 35 years.
So I think we should begin with a history of finding factors which could have potentially caused a TSH to go low. Some common scenarios are, it would make sense to ask for the last menstrual period, because in the first few weeks of pregnancy, it might have been undetected, but the HCG can have TSH-like action, so you can get a TSH which is suppressed. And it does throw a googly even when you've seen hundreds of hypothyroid patients. So that's always a good place to start. It would also make sense to ask how regularly they were taking their medications the year before and maybe this year. I think it's very common for people to take it regularly for a few months, and then when life happens, not take it regularly. That's a very common cause of TSH fluctuating. And the third could be maybe a weight loss, or going with what Dr. Rana said, although the textbook does say that it's ideal body weight, but we have seen people who've lost, let's say, 5% of their body weight have a lesser requirement of levothyroxine, especially as more and more people are going in for programs which help them lose a lot of weight. It would also help to ask, like Dr. Prasanna said, if they're taking any other naturopathic or homeopathic supplementation. Sometimes they do that. For some reason, the dose of the levothyroxine they take really matters to them, whether they're taking 25 or 50. So if a homeopath is giving a small dose of homeopathic medication, reducing the levothyroxine dose from 50 to 25, they count that as a win. So that is also a common scenario which does happen. I think supplements are also an important factor. Biotin is present in many supplements, and the immunoassay which is used to run your thyroid hormone levels uses biotin as part of the complex which is used to do the sandwich assays, so that biotin can interfere with most free T3 and free T4 probably more, but also interferes with TSH and could cause a low TSH values. So asking them if they're taking any supplements for hair fall is a good way to begin with. Also, maybe a hospital admission in the recent past would explain a transient depression in TSH. I'll check if the other panelists have any other.
Right. And how important or common is it that change of brand, does it lead to significant different bioavailability and so different TSH on the same dose?
Yes, I think that's an important point. I think the reverse of it is what we see commonly when they switch from their normal brand to maybe a brand which is not from a company which has a tight quality control process, and we see TSH going high, but the opposite also could potentially happen.
So, Dr. Parag, so we have for you another case scenario. This is an 80-year-old elderly gentleman who complains of mild weakness and forgetfulness, and whose TSH is 7.5. The general practitioner has got a TSH 7.5 and referred to you. So how do you deal with this?
So I think as we have discussed, Dr. Rana also highlighted, TSH of 7.5 at the age of 80 is absolutely normal. You don't really need to treat or worry about it. Actually, it's other way around. Actually, it's a sign of a good adaptation, and there are some studies that it shows a good longevity also. Higher TSH after 80 years of age is associated with longevity also. So definitely we should not be treating or investigating for the cause of hypothyroidism in such type of the patients. And as we mentioned, if somebody is 80 and TSH on treatment is 7.5, we may not increase the dose of the TSH. We keep the thyroid medication on the same dosage. So I think it's a subclinical hypothyroidism. Even between 5 to 10, you have to be very careful not to overtreat such type of the patient. And elderly population is, as Dr. Anna also mentioned, is more susceptible to get the cardiac arrhythmias, cardiac events, and worsening of the osteoporosis. Even a mild subclinical thyrotoxicosis occurs. So in such type of the patients, I think we have to just reassure and tell them that your weakness or tiredness or fatigability or loss of memory or some constipation is not because of the hypothyroidism, and it's not going to benefit, and it may harm. So I think it's a clear case that we just reassure and just forget about it. We don't really need to do antibody or follow the TSH after 6 months or a year also.
Okay, right. So we come back to Prasanna Kumar. So it's a patient is on thyroxine replacement dose. So how do you monitor this patient? How often do we need to do tests? At what frequency? And what tests?
Basically, the minimum test you have to do is TSH. Once you start, this is for the physicians who feel that whether we should do more frequently, less frequently. If you look at the half-life of thyroxine and all, it's almost 4 to 5 days. So once you see that the patient has high TSH, you start. The minimum time you have to monitor is 6 weeks later. Many times I see every week, 10 days, waste lifetime. The earliest you see once you start treatment is 6 weeks. TSH alone may be sufficient many times, but it is not sufficient in many patients. When you see TSH alone may not be good because TSH shows last 3 weeks whether the dose of thyroxine they are taking is sufficient. But if the patient has stopped in between few days, you will pick up by free T4. It is not necessary, not possible to do free T4 in everybody. I suggest every patient you do TSH once you start. Now, there are two types of patients. Well controlled, compliance is good. You can do it once a year. There was a study 20 years back, how frequently to test in an adult when it is well controlled. They came out with a number of 18 months, and it is research. So right now in our country, well controlled, most of my patients, I ask them to come once a year. That is good enough. But if it is not controlled, you can call them after 3 months and then check TSH. Where you feel compliance is not, or there's a disparity between what the patient is taking and all, you can ask for T4 to check whether the compliance of the patient is good. Free T4 is also normal. In some patients, that TSH will never come back to normal. Why is it you have say 100, 200, 300 TSH is still high? When you check free T4, it may be even upper limit of normal. And that is where, especially in children, you must always check T4 also, preferably free T4, along with TSH. Otherwise, the cost to keep it minimum, TSH is alone, well controlled, once a year, not controlled every 3 months, till CSH becomes normal or free T4.
Right, that's quite clear. So come back to Chitra. So it happens in Kolkata quite often. I'm sure it happens in Bangalore once in a while at least, that you're treating someone for hypothyroidism, advise everything, the patient is ready to leave your clinic, but then comes back and asks, doctor, what about diet? What should I not take? What should I eat? So how do you, let's say, dispose of these questions?
So I
That's
think
unfair, maybe.
Yeah, I think as doctors, we should maybe try and understand where the patient is coming from. There's a lot of information on social media. I just recently got on Instagram, and now I understand why they asked this question, because there's so much information which is being flooding their stream about how certain kind of diet will help you reverse hypothyroidism. And I think that's the reason why they ask. There are people writing books which says the thyroid diet, which people do bring in and say, is this something that we should follow? So I think we should address it. But overall, scientifically speaking, there is no specific diet to be recommended in hypothyroidism at all. But certain things that which your patient might value if you give them this information is that if they are in the habit of consuming soy milk or soy related products in the morning, which is something which is becoming an increasing practice, it could potentially affect their TSH level by increasing the levothyroxine requirement. I think they would appreciate to know that. I think they would always ask us about cabbage and cauliflower, but we now have people doing kale smoothies and broccoli smoothies quite a bit. So those are also cruciferous vegetables. But there have been studies which have done to show that even if you're taking it like every day, it still does not affect your TSH levels or the levothyroxine requirement. I think it's also important to maybe go back and reiterate that your coffee and milk separated by about 30 minutes, those are important things. But I think the other question which they want us to talk about is, should I avoid chapati and gluten? Should I avoid processed food? I think that comes from the social media information that there's something called as an inflammation in your gut, which causes hypothyroidism. So I think it's also important to address it, that if you're intolerant to gluten, maybe then get it tested out, or maybe try and avoid. But overall, it does not seem to affect or change the management of hypothyroidism, avoiding gluten or processed food. But I think they want to address that. You do have some people who are tracking their anti-TPO levels every 3 months, although we tell them do your TSH only a year. So I think that's about
Right.
that.
Yeah, good. Thank you.
Dr. Shubhankar, just
Yes,
I don't know about rest part of the India, but people have started using non-iodized salt after specifically COVID. People have now started using non-iodized salt. So I think there is now
is it
again a
so?
huge challenge that people are using the non-iodized salt. In India, in Gujarat, 80% people now use non-iodized salt.
Anodized salt.
Yes. So
how is it related to COVID?
No. They everything which is natural is better. Anything which are added chemicals are harmful. So that we have seen, and now see lots of people suddenly TSH is going a little bit on the higher side, and we have started asking the history about which type of salt you are consuming. So I think I don't know about other parts, but this is very common.
Parag, where do you get this non-iodized salt? Because it is illegal to sell non-iodized salt, whether powder salt, table salt, Tata.
Yeah, but sir, it's available. It's available.
No. Do they have a pack?
Legally, yes, sir. I agree. Legally, but it is available.
No. Is it written there non-iodized?
No,
we
it's
don't
not
know
in
the
a
iodine
packet.
content.
It comes in big sacks. You just weigh it out. It doesn't come in a packet.
No. Even big sack, crystal salt 50 kgs is also iodized right from manufacture. So I don't think they will see it may be cheating. Just like people get, sir, all the sugar is taken out, you can take this rice any amount. Somebody may be selling like that. Has anybody checked non-iodized salt? As far as I know, it's not available. Sodium chloride, crystal powder salt, wherever it is, because if they have it, they are going to be jailed because it's a rule. Not today, for the last 3 decades. So I don't think anybody can officially sell non-iodized. People may say just to get more money, this is non-iodized, charge more. But it is illegal to sell non-iodized salt because many of
But
them
there,
have wrong feeling. When you take
yeah,
radiodine, don't take it. Where is it available for my patient? Nowhere, 30 years. I have not seen non-iodized salt packet anywhere.
but there was a move, let's say about 10 years back, when people said that this is impinging on our rights. You cannot force us to take only iodized salt. Non-iodized should also be available. And I thought there the government had relented and now we are allowed to sell non-iodized salt as well. I mean, that's, but I have to check on that. I can't be sure.
You can
Some
check. It is
rock salts,
illegal.
maybe, sir. Some rock
Rock
salts
No,
salt
no,
are
is not
there.
sodium
that's
Those
chloride.
are not
That
nowadays. So
is potassium chloride.
some people
And it
take
is
that
so
as well as a.
expensive. I don't
Yeah.
think you get 100 rupees one packet. I don't think any of the Indian families can use 100 rupees for one packet of 1 kg salt. You know, there are some which are set. That is only given to cardiac patients and others where potassium content is, I mean, the sodium content should be less. Otherwise, I don't think routinely any Indian family uses rock salt.
No, sir, it's very common in Gujarat to use a rock salt.
Non-iodized salt is available on Amazon India, sir.
Non-iodized salt.
Yes, sir. It says non-iodized salt.
I don't know.
Maybe that's
News to me.
anyway. Yeah. So we have Dr. Jyoti Khanna asking about a patient, 69-year-old lady. Oh, it's not mentioned. So history of hypertension and diabetes with TSH 12.5 on 550 microgram of thyroxine. Kindly guide follow-up. Yeah. So Parag,
Yeah, I think
so at 69 year, will you be increasing the dose? Is
yeah,
possibly the
so
question.
12.5 is the TSS, so we might increase the dose based on their
Right.
body weight and other comorbid
Right.
conditions.
Right.
Maybe 12.5 to 25 microgram we can add and just follow them up after 3
Right.
months or so.
Good. So I think we looked at type 1 diabetes. We had a look at hypothyroidism. Of course, we have not allotted enough time for any of these discussions to be foolproof complete. So, but now let's try and peep into postmenopausal hormone replacement therapy for maybe the next few minutes quickly. So, Rana, I think if I remember, maybe it's not a time when you were in active practice or in endocrinology, but in my earlier practice, it was fashionable to advise to discuss hormone replacement treatment with ladies. And if you did not raise this issue, possibly you are not doing enough service to your patients. But this has changed a lot over these years. So why has HRT not lived up to its expectation, Rana?
So causes are possibly many, but possibly the most important cause is earlier there was a perception pre-WHO, rather Women Health Initiative, that it's kind of a panacea. I mean, if you use it it's a kind of help in maintaining youthfulness. Or in addition, most importantly, it also leads to cardiac protection and all. But WHO clearly showed that it's not at all beneficial. It's really harmful if you use it in a relatively older population, that is 10 years post-menopause and possibly more than 50 years of age, maybe 60 years of age. The average age, mean age of WHO is around 65, 66. But the problem is that that led to a media hype, and there was a fear regarding this hormone replacement everywhere. So much so that even there are some resistance, even when you use hormone therapy in a patient with premature ovarian insufficiency, where it's really indicated it has multiple benefits, plus a woman with significant menopausal symptom along with maybe other factors like osteoporosis, if we use it early, within the 10 years post-menopause, or between the age, say, from 40 to 50, even up to 55, there are many benefits, and benefit clearly outweighs the risk if we have a proper patient selection. So I think it's again coming back a bit, then say around 10, 15 years back, when there was a fear regarding this HRT, but again, with the available evidence of its safety in a relatively younger postmenopausal women, and judicious use of hormone replacement definitely helps in many ways, and it clearly outweighs the risk.
Right. So postmenopausal osteoporosis is a reality, and there could be different ways to address it. So Dr. Parag, do you think you would be advising HRT or a bisphosphonate or one of the other anti-osteoporotic agents?
See, less than 60 years of age, if there is a osteoporosis, the health, osteoporosis and bone health benefits are similar whether you're using the bisphosphonates or HRT therapy. So you can choose either of two for the bone health is concerned. Yes, younger for some other reasons also, somebody has a pre-existing condition for osteoporosis and developed menopause, and within 2 years had a significant osteoporosis with a vasomotor symptoms or other symptoms of a post-menopausal or a perimenopausal. I think estrogen therapy is a safe option. It improves the bone density and reduces the risk of fracture. There are some studies that less than 60 years of age with a severe osteoporosis, you can consider giving both estrogen as well as bisphosphonates also. Or those who are on a bisphosphonate intolerant or not going to afford the anabolic therapy, you may give an option of a hormone replacement therapy if somebody is 60 years or below with a osteoporosis, intolerant to denosumab or the not affording for denosumab or not tolerating the bisphosphonates.
So we don't have much time on our hand, but Chitra, could you quickly tell us who, I know it's a tall ask, but who are the ones who should be receiving postmenopausal HRT, and which preparation and for how long? Is it only for menopausal symptoms?
Thank you for the question, sir. So the only approved use for menopausal hormone therapy is for the treatment of the vasomotor symptoms specifically, maybe not even other quality of life related aspects like, let's say, insomnia or mood disorders. So vasomotor symptoms are definitely something which need to be addressed, and they are very common and prevalent. It's generally believed that they are less common or less prevalent amongst Asian women, but there is now evidence coming in from parts of Southeast Asia like Korea, which does say that its prevalence might be as high as 40 to 50%. So it might be important to ask proactively about these symptoms. First, of course, we would like to think of non-pharmacological treatments, but hormonal therapy is also something to be considered. It's important to consider absolute contraindications for this therapy because, like we've said, we've been through the whole roller coaster of the safety of it. So looking for history of venous thromboembolism or pulmonary embolism is important, and also screening for breast CA and endometrial CA is important before we even begin this conversation. So we need to screen with a pap smear and mammogram. Many women reach menopause without even one screening test for either of these conditions. Of course, we would want to screen for other metabolic conditions like blood sugar levels, cholesterol, liver function tests before we even consider having a conversation about this.
So will those be contraindications?
To choose
sorry,
the lowest.
Sorry. Would those be contraindications to the use of HRT if someone is found to have diabetes or is hypertensive?
Those are relative contraindications, but the absolute contraindications would be history of pulmonary embolism or venous thromboembolism and also malignancies which are estrogen responsive. But the hypertension, hypertriglyceridemia, and elevated liver enzymes are all relative contraindications. What would you choose to use? The most commonly available preparation is oral in our country, although we do have sporadically estrogen patches which are available at least in Bangalore, but it does go out of market quite for long, significant times. So you could usually use a combined oral estrogen and progesterone preparation, but if you want to lower the estrogen exposure and maybe use a lower dose, it might make sense to separate the two. Another way of using it is to use a lower dose of estrogen along with a progesterone containing intrauterine device. That is also an option which is recommended now. For how long is a difficult question to answer, because the symptoms do get better while they are on hormonal therapy. But as you try and take them off it or give them a window, after a few years, symptoms do come back, maybe not to the same extent as it was. So that is probably something which we'll have to figure out on an individual basis. But there are concerns about long-term safety and use that we're thinking about, especially if they've been on it for close to 10 years or so. So we should probably be attempting to stop it at some point. In the interest of time, I'll stop, sir. So you're muted.
Yeah. And Dr. Prasanna Kumar, so how would you monitor someone who's on HRT?
Yeah, basically, Dr. Chitra has already told us how initially you take history, family history of breast cancer, ovarian cancer, or even her own history, whether she has any disease, she's on a medicine, dyslipidemia, or whether she has got mental diseases, Alzheimer's and all. Once you start, it is necessary every year to check the physical condition, because many times estrogen therapy can cause hypertension, diabetes. So these are the history and examination to see whether she has developed DVT or not. If any of them occurs, from the safety point of view, better to stop the medication. Apart from that, previously it was every year. Now once in 2 years, you can do breast mammogram or ultrasonography. You can also do a pap smear and gynec examination, and even the ultrasound of the pelvis to rule out the diseases. So these are some of the things which you have to see, not only taking history regularly, clinical examination, investigation like lipid profile, checking blood pressure every visit, and see the complications or the side effects of the hormone therapy does not occur, and see that, talk to the patient, and if you are satisfied, then only continue.
Thank you very much. I think we have covered a lot of ground. We still have one question in the chat box, Dr. Gaurav, and let's have Dr. Parag Shah answer. How to start thyroxine replacement therapy in a patient with a history of angina, coronary artery disease. Kindly guide on dosage and precaution monitoring required. And sorry, we didn't cover this part. So yes, Dr. Parag.
Yes, if somebody has a high risk for arrhythmia or a coronary artery disease, if somebody has a subclinical hypothyroidism, meaning thereby TSH is between 5 to 10, better to avoid and just observe the patients and see if the TSH is rising or not. If TSH is clearly elevated of more than 10, start with a smaller dose. Don't go by the body weight dose or full replacement dose. Start with a small dose. There is no hurry to control the hypothyroid and make the patient euthyroid. So start with a small dose, repeat the TSH after maybe 8 to 12 weeks, and then try to keep the TSH on the upper normal range rather than trying to keep in the low normal range, and not overtreat, and TSH should not go below 0.5 by any means in such high risk populations.
Right. So those are absolutely wise words from Dr. Parag Shah. So I think we don't have any more questions. So I can only thank all our speakers this evening. We did understand about the nuances, a little bit about the nuances of management of type 1 diabetes, that just pre-mixed insulin is not optimum treatment for type 1 diabetes. Should be multiple subcutaneous insulin regimen with basal and boluses. And it requires significant amount of time and effort to be explained about what to do, how to do, how to follow up, and quite often requires significant family support, especially for a small child. But at the same time, we do realize many a time that the child actually may be overprotected by the parents. The child can inject, self-inject, can do the tests. They're smarter than their parents many a time, but the parents quite often do not allow them to self-inject. So we need to be their advocates as well. About hypothyroidism, and we could go on talking about management of hypothyroidism whole night. Still, we would not cover, but we did understand that we have a starting dose or a replacement dose, which can be mathematically calculated. But of course, there will be many situations where we start with smaller dose, and there are some conditions where we start with full dose. And in the elderly, especially, we do remember that keeping the TSH a bit on the higher side actually may be to the advantage of the patient rather than getting it too low within the normal range. And finally, hormone replacement treatment, we did understand it has its advocates, it has its benefits, and we should not deny patients just because there has been a hue and cry about its safety. We should be properly monitoring, properly selecting, and then of course we can use hormone replacement treatment in postmenopausal women. So once again, thank you very much, Prasanna Kumar, Parag Shah, Rana Bhattacharya, Chitra Selvan, for your kind words, for your wisdom. And again, many thanks to the INTAS team for egging us through and arranging this wonderful session. Hope the physicians could benefit somewhat. And I do have the numbers that have been provided because of all the excellent speakers that we have this evening. We had more than 1,000 people, physicians from different parts of our country logging in to get some of the pearls of practice in endocrinology. Thank you very much, all of you, and thanks to all our physician colleagues. So back to the organizers.
Yeah, very good evening, doctors. Today again, we had a very good discussion on the topic being posed to all the panelists. I'm sure all the attendees will go, very rich in content with all their queries being answered on this relevant topic being given. On behalf of Intas Pharmaceutical, makers of Dapavel and Ignalis-M, I would like to thank individually all the panelists, especially Dr. K.M. Prasanna Kumar, Dr. Parag Shah, Dr. Chitra Selvan, and Dr. Rana Bhattacharya for sharing their expertise, their experience on the patient profile which was being discussed and value adding throughout the session. We, on behalf of Intas Pharmaceutical, are ever indebted to Dr. Shubhankar Chaudhary for being the backbone of the session. Doctor has just mentioned the numbers actually, which has of attendees, which has kept on coming month on month, every month, and the numbers, exact numbers which has got registered today was around 1189 doctors. So I'm extremely thankful to Doctor, for keeping our audience hooked on to this session by coming out with interesting session month on month. I would like to thank individually all the attendees who have been supporting this program for so many months by now. I'm sure you will, in future programs, will also keep you attracted and will keep value adding each one of you. Thanks for sharing the evening with us. And I would like to again thank each of the panelists, wishing you all a very happy weekend. Thank you, doctors.
Thank you. Very good night.
Good night. Good night.
Thank you.
Good
Thank you, sir.
night.
Good night, sir. Thank you.
Good night.
Good night.
Thank you very much. Good night, sir. Good night. Thank you. Good night, ma'am.